Curious about what's new in the 6th edition of Clinical Sports Medicine, the key lessons from writing it, and practical insights on PRP and cortisone for tendinopathy? In this episode, I'm joined by Dr. Karim Khan, sport and exercise physician, professor at the University of British Columbia, and co-author of the classic textbook, who has worked with Olympic, professional, and ballet athletes. If you're new here, don't forget to subscribe and hit the like button so more colleagues can find this content and so you don't miss future episodes. Now, let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Neck care.
Treating neck impairment? Get objective neck assessments with the Neck Care system. Learn more at neckcare.com.
Hi, Karim. Welcome to PT Pro Talk. How are you today?
I'm great. I'm looking forward to chatting with you. I'm a big fan of your podcast and great to be on it.
Awesome. It's been a while, so I'm super excited that we finally got you here. I know you've been busy with your book and everything, so I'm happy that you finally got some time to come here and chat with us.
Yeah, very kind. Looking forward to learning from, I love learning from your podcast, and I hope folks can enjoy this one.
Very good. So let's just get started talking a little bit about yourself and your background.
Sure. So I think I come from a medical background, so different to many of your guests who are physiotherapists. But I like to consider myself as a wannabe physiotherapist, someone who really believes in the power of physiotherapy and an ally, of course, and a supporter, because when I started working as a young doctor, I was fortunate enough to be in a multidisciplinary clinic that had been set up by Peter Bruckner and physios. And we had massage therapy and podiatry and sports nutrition. It was very fortunate to begin in that setting as a young doctor. And then that's where I really learned the power of physiotherapy and the quality of great physios, because in the medical training, we didn't get that emphasis and there wasn't a good explanation of the benefits of physio. So I worked for the listeners, background, I've worked in a multidisciplinary clinic. I've worked with teams. I'm fortunate enough to work with some Australian teams in basketball and particularly, but some other sports. I was part of the Olympics in the year 2000 in Sydney, so that was a very fortunate opportunity. And then the last 25 years or so, I've been in Canada and being a professor at the University of British Columbia in Vancouver in Canada. And that's been a great opportunity to push on with some research and some book writing, as you know.
Just a quick pause to share something exciting. I've been working behind the scenes on a tool to make prescribing home exercises easier and faster for PTs. It's built based on feedback from therapists who have told me they are tired of clunky search tools, limited customization, and complicated sharing. I will be sharing more soon, but if you're curious and want early updates, you can join the interest list using the link in the show notes. All right, let's get back to the conversation. Very good. And we know that there is a new book coming up. So would you like to just tell us now, it just came the 6th edition, right? So tell us a little bit about that.
Yeah, I think the purpose of the podcast is to share clinical tips and clinical experience. But, for context, I think quite a few of your listeners will know the book called Clinical Sports Medicine. And so the important, exciting news from our team of 100 authors really is that we want to be helpful so people don't buy the wrong book by accident. It's really the concept of the books now, the books as in plural, because our field of sports physiotherapy and sports medicine has gained a lot of knowledge since we first had the first edition of 700 pages in the 1990s, which will bring a smile to some people's faces. And so now there's a book for students, which is called Foundations of Clinical Practice. And that book's out, available on Amazon. And so that's a concrete product right now, Foundations of Clinical Practice. And my message is, if you're an experienced clinician and you're looking for the update on how to treat knees and shoulders, don't buy Foundations of Clinical Practice. And that's, half a joke because we love the book and I think it's very exciting, but it is what it is, and it's geared for students so they can learn about the pathologies and learn about the principles of shared decision making and how to be a great clinician and the fundamentals of what are stress fractures and what are tendinopathies, all that really important science, fundamentals. That's why it's called Fundamentals of Clinical Practice. And the cover has sprinters coming out of the block. So it's this idea of a starting of your career as a sports physio. So we just want people not to buy that book, by mistake. And then the main book, which is the part of the old books, the main section where physios would wreck the book because they were using it so much in the clinic and it would fall apart, that was how to treat from the head to the toe. And so that's its own book now called Managing Injuries. And we're calling them books, book 1, book 2, so as not to confuse things from past volumes. So really there are 2 great books for physios, one of which is ready and one of which Peter and I and the 100 co-authors are finalising the page proofs right now. And that'll be available in January, February of 2026. And then we're all going to take a pause before the medical book gets out, which will only be in 2027. So nothing to worry about for your readers for now on exercise and diabetes, exercise and asthma, which physios play a role in that as well, the health promotion. And that's called the medicine of exercise. But I think for now, someone's got an old copy. What's new for them is that the part A of the book about the fundamentals is its own 400-page book. And then that it's allowed us to really pack the value into this treatment manual, which is called Managing Injuries. I didn't mention that before. So, we feel that Managing Injuries is the book that clinicians active, the sort of people who are listening to your call as well as the students, will go, okay, that's Managing Injuries. And the last thing about it's not a marketing call, but I think we just want people to understand what they could potentially purchase. Is that by splitting the books, the prices are better. Obviously, the 400-page book is under $100 with fantastic illustrations. And then the Managing Injuries, which we're very excited about, which is coming out in January, February of 2026, is just packed with more information now. By taking out the fundamentals, we've been able to put more treatment. And that's what we're going to talk about today as well. So I hope that's helpful. And Mariana.
Yes, no, that's very exciting. And just curious, what date was the first edition released? Do you remember?
Yeah, I do. It was 1993. So it'll be before many of your listeners were born. And, the short version is that there wasn't sort of one single book for physios and, primary care clinicians. The sports medicine books had been tended to be written by orthopedic surgeons. And so they had this orthopedic bias. And our publishers, McGraw-Hill, were visionary enough to say, look, there's a need for books by the people who work in sports medicine settings who aren't orthopedic surgeons, led by physios and doctors who aren't orthopedic surgeons. No offense to our orthopedic surgeon colleagues. And we like to think the book has this integrated multidisciplinary approach because we do have orthopedic surgeon author, but, it's been dominated by physio authors numerically, as you know.
Mm-hmm. Yes, no, very good. And just curious to ask you, what will be the difference on this last edition comparing to the previous one?
Yeah. And that's a great lead into, today's practice, maybe with my perspective as an older, person. It's what's changed. And what I'm excited about is that we have way more evidence for the benefits of exercise, subtext, the benefit of physiotherapy, than we did in earlier editions. And it's actually been more than 10 years since the 5th edition. So there's, no one has a recent edition because it gets this issue of how quickly can you pump a book out. And Peter and I aren't, and our co-authors who do all this hard work, we're not in the business of just having books for book's sake and trying to make money. Honestly, authors will tell you that they actually don't make money, and it's just the publishing industry isn't the way to make a lot of money. I think AI is, and stocks, and there are other ways of making money, real estate. But we just takes us that time to put the quality product out and work with the authors, and we wait for the field to have changed. So, we have all this new evidence, all these randomized trials that you know very well, in the sense of, randomized trial after randomized trial coming out in the leading journals like JOSPT, British Journal of Sports Medicine, Physiotherapy. These journals are packed with literature, and I'm a full-time academic and I can't keep up with the quality of work, the volume and the quality of work that's coming out in our field, as you know, and as your listeners will know, because your listeners are keen and they learn. So that's very different, because when, the first book was being written, we were saying, well, we think manual therapy works, or, we think exercise works, like go try it maybe. And there weren't any publications, not even a case series in a lot of cases. And the idea of randomized trials, that's for the younger listeners. It'll seem like a pre-internet era or pre-iPhone era. There weren't randomized trials in our field because, the universities didn't prioritize sports physiotherapy, sports medicine. So there were hirings in cardiology and hirings in cancer, but there was no professors in our field. So it's hard to get, and the grants weren't being given to sports physios, whereas now you've got people like Kay Crosley, and Claire Ardern, and, these big name physios who are getting grants because they're professors and they're able to get into the funding agencies at the national level with millions of dollars of grant opportunity. And by being super in their work, they're able to get these grants. So this book is packed with all that evidence, which I think will give clinicians confidence, without having to try and do the systematic review and evidence-based, like, okay, how do I treat, let's go with, the ACL controversy right now. And so in a good way. So it's like, okay, here's a summary of the surgical options. Here's a summary of the fact that rehab is a good first opportunity in most cases, a first thing to do for most athletes. It's safe to do an exercise-based program. The results of 50% of people don't need an operation. Here are some complications I could look for in the clinic of why they might not be getting better. There might not be enough of the right type of strength work. This is from Horvath Moxness and Hege Grindum, the leaders in the field. So, I'm just giving that as an example of what you wouldn't find in older books or other books. But I think, Mariana, there is the whole concept of the book, so I don't want to go on, but I think you'd agree that it's good to say, well, what about you can ask the difficult question, what about the internet? Why don't people just go to their phone instead of using a book, right?
Yes. Yeah.
And I think the answer is the challenge with artificial intelligence is that it can't be trusted at the moment. And, obviously artificial intelligence is massively going to influence our field, and already is. Of course, we use it all the time. So if a listener is expecting an old person to try to pretend that AI doesn't exist, I'm sorry to disappoint you, but clearly it's massive. But it just can't be trusted at the moment. So a good concrete example, we used to put quotes at the top of a chapter. So if we have the patella tendon chapter, we had a quote about Steffi Graf as a tennis player, or Serena Williams. So, I went to AI and said, I'd like a quote from a great athlete about patella tendon pain, say. And the AI spits back, these wonderful quotes going, well, this is good. This has made my life easier. This is great. We used to do a lot of work to find these quotes. And then it turns out that it's completely made up. It's not a real quote. And so I go back to the AI and say, you sure that's a real quote? And it goes, no, it's not. Like, we just sort of have a go and try and make quotes that sound like they could be appropriate. It's just like, okay. And so then Pam said, oh, that's a quote, but what about treatment of shoulder dislocation? And I did this. This is a concrete example. And so I was looking for a picture of a shoulder dislocation. And we know, this is all going to be done by AI in a while, but it's just not ready right now. So it showed the picture of the shoulder dislocation, but the anatomy was completely wrong. And so the humerus and the glenoid humerum, the glenoid labrum, were wrong. And so I said, you've got a problem here because, you've dislocated the shoulder in the wrong way. And he goes, yeah, sorry. Yeah, here's a better one. And that one was wrong as well. And so, and we know that doing the art is complicated, and, they're large language models, let's be honest. And so they're not there yet, but it's just important to be aware of that. And then this most recently, and then I'll finish on this set of examples, I was looking for one particular BJSM cover photo from British Journal of Sports Medicine. And instead of Googling, or instead of going back through the old issues, I said, what are the top five best five covers of BJSM? So that's a reasonable question to ask a large language, AI. What are the best five covers? Because the covers of British Journal of Sports Medicine are attractive. They have athletes, things like that. So it came back with some answers, and it was like, oh yeah, these are pretty good answers, like the concussion issue, the mental health issue, things like that. It's like, yeah, the London Olympic issues come to mind. And I knew about those issues because I had a bit of a role in journal editing, as you know. And then it turned out that they weren't actually the issues. Like there was no COVID issue. That was an example. It was like the COVID issue. It had a paragraph of saying how the COVID issue dealt with these things. There has been no COVID issue of BJSM, and with respect to the past editor, I know that, and the current editor, there's been no COVID issue of BJSM. And then the London Olympic issue was a wrong date, and the mental health issue was a wrong date. So it just made up, very convincing. And if you didn't know about the covers of the British Journal of Sports Medicine, it was treatable. So moving this into treatment, if I ask how to treat something, I'm going to get this large language model merging all the different treatments of the exercises, the manual therapy, potentially the injections, and it'll just do its best, but it's not reproducible and it's not evidence-based because it doesn't extract, the literature. So I'd say right now for treatment, clinicians are better off with papers where it's actually a real thing. And obviously there's a competitor like UpToDate and those softwares that are not based on AI. And I'd argue that we have better illustrations, we're more practical, but it's not a debate about what's best. I'm just making the point that AI can't be trusted for treatment at the moment. But if you know a lot about it and you want some options, that's okay. So people are using AI in their own ways, and I'm sure people are using it in the clinic in certain ways, maybe discussing options once it's come through the AI as a suggestion. And so I think it might be an interesting topic, for various podcasts and things. But just the update today is it's not ready for prime time. And in our book, you've got 100 experts in your pocket. You can flick to the page. And then we want to support that with our website to update things, which is obviously an important issue. So I'll pause there and hand it back to you, Mariana.
Yeah, no, I think it's great that you point that out because I've heard other people talking about the same issue. So we still have value on having people that summarize all this great information that are credible, and you can just go and look, and it's not going to change. It's printing paper because really we don't know if you can trust on the information that we find, because I had some issues also with AI. So sometimes you just trust that you're going to give us the right information, and it's not. So for sure, I think the books have their place, still have their place, and it's good to get all these great clinicians and information together. So for sure, it's very valuable, and it's a good warning to just not trust 100% on whatever AI tells you. And I'm gonna have a guest soon talking about AI as well, so I'm curious to see his point of view on AI. So that's coming. Okay, moving on then. Since I know you've been writing this for a while, so I just wanted to ask you if you have some key takeaways from your work. I know you work a lot with physical therapists. So what are some things that you learn in this whole process that you would like to share with us?
Yeah, thank you. I think if we focus on the foundations of clinical practice, I think the shared decision making is coming to the fore in our field in a way that many clinicians on the podcast, listening will be saying, look, I do shared decision making anyway. So a young patient comes in, let's stick with the young athletes, make it 14 years old and maybe 12 years old even. And there's issue about ACL rupture and then surgery at the young age or non-surgery and that whole complicated thing. You've got the parents because it's a junior person. And they'd say, look, we have that discussion, and that's great. And I'm confident they do. So I guess, we've just formalised it in this particular book, Foundations of Clinical Practice, to have a chapter on the steps of that, pulling the literature together on shared decision-making, being up to date. And Claire Ardern has done a great job of giving cases in the book of how to work through the cases. And that's because we're trying to be practical. It's very case-based, and that's where the illustrations come from. And so there's a picture of the handball player, and then there's the discussion. So I think shared decision-making is getting much more credibility. I think physios have probably been better at it than doctors over a period of time. I think doctors might have been a bit top down, like I'm the doctor and I tell you what to do. It would be interesting to have a camera in our surgeon colleagues' consulting rooms when they're discussing ACL surgery with patients and listening to how they actually communicate, whether it's about, whether there's talk about the options and really empowering the patient, or whether they're sort of pushing towards a surgical angle, because of the reasons that they might think make surgery a better option, which is, I'm not saying right or wrong, but it just would be very interesting to have the audio camera in the authentic conversations to see how that's going. So I think for each listener, I wanted to make the point that it's difficult for time though, right? Like in your clinic, you've got a certain amount of time, you've got to get through the patients. And I think doctors are better off, more fortunate in some ways, because sometimes people think, well, I'm paid, the time I've got, the doctor's meant to talk to me and explain stuff. And my wife just had a fractured wrist and she's had great effect from a physio. But even Heather, who's knowledgeable and experienced and got a lot to do with physios, she was sort of wondering about the time of explaining and the time of treating, like hands-on. So it gets to this hands-on, hands-off discussion. And my point there was, I think we've got to try and educate the patients more to realise that if the physio spends 45 minutes explaining things and, what's going to happen, assessing, of course, first, and then explaining, there might not be a lot of time left for treatment in the first consultation. And that's relevant, in the shared decision-making process, of course, because that's where you're having that discussion and deciding which treatment option to go. Versus, I think the stereotypical old-fashioned thing is I go to the physio, we have a couple of minutes talking, and then bang, the physio starts doing hands-on treatment, which isn't the case. And the physios on the call know that's not the case. So I guess what I'm sharing is this wrestle, the wrestling with this concept where we've got to try and educate the consumer to be more aware of just that one simple example of physio, but even more broadly, I'd say as an advocate of physiotherapy, patients don't realise the value, and a lot of them end up in other clinical settings, when they could be getting better value at a physio. So I'll pause there on shared decision making, Mariana, and see what you want to do from there.
Yeah, no, I think that's something that people are talking more and more lately. I just had a conversation about motivational interview, and we discussed a lot about the shared decision making, how it's important to get the patient on board versus just telling the patient what to do. Like, you know everything, they don't know anything, and you are the one with all the answers. So I think this is something really important to get, the patient to their buy-in to getting the treatment and understand the point, make sure the goals are aligned and all of that. So I think that's super important to get the patient participating in the treatment and the decision making and everything.
Yeah, no, I think I'm glad you've got that. And we know that some patients say to the clinician, what do you think? And so then they're going, look, you're the expert, and if you were me, what would you do? Which I think is a reasonable point to make if they want to do that and in that context. But I think one shouldn't assume that that's the angle that they want to take. And
Yes,
it does take
yes, it
time.
depends on the patient for sure. Yeah. Anything else that you wanted to discuss from the process of writing the books?
Mariana, I was really happy to get a chapter in about athlete education and patient education. And actually, this book, Foundations of Clinical Practice, opens with a chapter by patients. And so, this is relevant from moving on from shared decision making, because obviously the patient's at the centre. And there's a lot of talk about that. And what you and I are saying, what you were saying in your explanation about the discussion about shared decision making, the patient does have to be at the centre. And we open the book by saying that in our first edition, we had the patient at the centre of a drawing and we had the clinicians around it. And we were saying, sports medicine, sports physio should be delivered in a patient-centred way. But we actually didn't give the patient a voice. And so we're really apologising effectively by saying, well, we said it, but ironically, we didn't do it. But now in this sixth edition, the first chapter is called The Patient, and it's written by patients. And so there's an introduction by Peter and me saying, apologising like I just did, and saying, here's the patients. And so the patients write it as, we believe this, and these are the challenges that we have when we're seeing, clinicians, and here's how clinicians could be even more helpful for us as patients. And then that's chapter one. And then we later on, from there on in, we as the clinicians, right, we should do this, or you might want to consider doing this treatment. But that first chapter is written by patients, which, we're super excited about, and really grateful to Dawn Richards for leading that, with Joe Belton, an American writer. So moving from that into athlete and education, that's never been, in the book before in any previous editions. And of course, again, education is one of those things that physios are very clever at weaving into the consultation when there's these expectations to do maybe hands-on treatment. And yet they're educating, so there's shared decision making. I'm separating the shared decision making where we might say, yes, I don't want to have a surgery right now, I want to go with physio, to education, which is like, okay, this is the type of exercise I should do. So learning the exercises that you need to do as a patient. And I've been a patient, so I can wear a patient hat in terms of, getting the exercises, not losing your piece of paper or the, videos with the exercises between and then doing it. That's all part of patient education. And then load management is obviously a massive part of patient education in our world, and learning about that. So there's a separate chapter on load management, but, patient education chapter has the principles, and Paul Blasey has done a very good job of that, and brings in the clinical principles that are important from all that literature on psychology and education. So doing education in a good way, rather than just when I was a young doctor, I just was trying to educate the patients, but I wasn't using it based on the principles. I wasn't evidence-based education. It was Karim's education, which of course is scary and not ideal. So I like that's a thing I learned from that process of creating a new chapter with Paul Blasey on athlete education.
Yeah, no, I think that's great because I think it has been a lot of progress in this area over these last few years. You're talking a lot more about this. So it's great that you have this updated version with this new information, right? On the book, we're talking a lot about patient education, shared decision making, these things that, it's coming up a lot more in these last few years.
Yeah, and if I jump on that to wrap up, the new things, just a few highlights of the new things. Obviously, there's the principles of treatment and the principles of rehab. So way more on pain science. Of course, there's 2 chapters on pain science, as you can imagine, and we're super happy that Lorimer Mosley gave us a brand new chapter on pain science and in very practical angles, and then a clinical chapter applying that in a clinical setting. So, but that's not just in chapters; it goes through the book. So when we illustrate the slump test in the examination, and we have the whole idea of pain science throughout. And so these updates on the fundamentals. So this is still under the foundations, but it's updating that science that we use in clinical practice.
Yeah.
And then there is a chapter on surgery for the first time. So it shows the key surgeries for the different body parts, shoulder surgery, ankle surgery, when you may or may not do it, beautifully illustrated. So I think that's going to help some physios who aren't sure sometimes of what the surgeries are. And then I'll close out on return to play, sort of a logical, last chapter in that particular book, where Claire Ardern has written, and it's a brand new chapter for us because we didn't have her in the clinical sports medicine team 10 years ago. She was just wrapping up her PhD almost. And so great to have that return to play so recent from her. So, yeah, I did learn a lot, as you say, and making the point that I'm really confident that experienced physios will get a benefit, but I just don't want them to be, buying it thinking it's the treatment book. So get one of your younger people in the clinic to buy it, or a student, and steal their version and just skim through it as an experienced clinician and go through the bits that you like.
Yes, no. And you're just learning from the best of the best, right? All these names that you just mentioned. That's awesome. Amazing. And you mentioned some cases of surgery, no surgery. So I was going to ask you if you want to bring up some cases, maybe talking about, the surgeries from the doctor perspective versus non-surgery with the physio perspective.
Yeah, I think a good one where I might have some credibility, and I'm conscious for the readers, for the listeners, that I'm not in the clinic anymore. I've retired from clinical practice, but obviously I engage with folks who are in clinical practice, and I'm heavily in the literature as a professor of sports medicine. But I just want to be transparent about not being in the clinic I was in a clinic as a patient after my hip replacement surgery, and the physio was fantastic. So I was on that end of it, and the exercises were amazing, and the surgeon was commented on how quickly I recovered, but of course it was because I went to physio the day before, 3 days before the surgery, of course, and check in, and I was in, and then I went 3 days after the surgery for my first post hip replacement, visit, and they told me go in 3 weeks to the physio. It was like, by 3 weeks, I'd been 3 times to the physio, not just once, and I'd been doing exercise. I'm not perfect, but I wasn't terrible at that stage. And so, of course, as someone who understands the benefit of understanding the value of physio, I was able to just get all this rehab because the surgeons were very happy for you to load and do as much as I liked effectively, well, except a little bit of hip flexion, as you know. But it was just a credit to the value of physio. And so at the 8-week visit, I was jogging in the corridor when they were saying, can you walk? It was like, and I wasn't being a hero. It's just like, that's what you can do if you get appropriate advice. I was safe. I wasn't damaging my hip because it was meant to be used straight away. But you can just imagine if I'd lay there for the first 3 weeks not doing anything. Of course, we all know, but it's just interesting that even this great surgeon had said, go to physio in 3 weeks, and in the Canadian system, in our local area, you get 4 free physio visits even, which is a good sign, right? So the government, I would have paid, and of course, happy to pay and happy to go and able to, but I'm making the point that the government supports physio, and again, they realise that it's evidence-based to get people back quicker by funding 4 visits, which is not enough, but it's okay for a hip visit and 14 for a knee replacement visit. But, moving to sports, of course, but this is exercise, right? This is part of musculoskeletal physio and orthopedic physio, and so very satisfied customer here. So I think the point I was going to, in terms of learning, is the evidence for physios going up, which I've said. And I wouldn't mind talking about tendon injuries, which was where I was going with clinical practice, is that with a long-standing, let's call it Achilles tendon, problem, there's this discussion for the physio about should I go, if it's not working, if physio isn't working out, is there pressure for a physio to refer to a doctor for an injection, and then it gets to which injection of cortisone, PRP, you could have a list of 20 things, and sometimes there is a list of 20 things, or potentially surgery. And this is where, with my experience, I can sort of give that 20-year, 30-year picture, where one good thing is that the rush to surgery for tendon problem has much, much declined compared to when I was a starting doctor. So, in those days, if a physio had seen a patient for 2 months and the patient wasn't better with their tendon, there was this pressure going, maybe you need to go to surgery. And clearly now, I think most folks, well, it depends on the countries, and you have a lot of, listeners from different countries. I'd say that in, the leading sports medicine countries in the world, and that's a value judgment, the surgeons aren't encouraging early surgery because I think they're frustrated because the surgery doesn't work so well. They just have an unhappy patient coming back to them going, I'm not better. I think much less pressure on tendon surgery than there was over that time span. And I think Jill Cork, Karen Silbernagel, a lot of great shoulder tendon physios deserve a lot of credit because they've trained people to go, look, here's good treatment, but it does take time. And switching back to the ACL metaphor, you don't expect them to get back to playing sport with an ACL in 2 weeks. And, there was this thinking that somehow tendon injury should get really back quickly. But now with the ICON group having their consensus meetings and things, there's a feeling that tendons need time to repair. And so we've got to have a much more realistic time frame. So I think the surgery pressure is off over 20 to 30 years. The time frames are much more realistic over 20 to 30 years. And the confidence in the physio programs, and when I say physio, it's a good reminder that, physio isn't a treatment, like there's exercise treatment and physio is a job. And I get that. And I know there's discussion of that. And there's many different treatments. You wouldn't just say medication for all kinds of antibiotic diseases. It's like take some lucky medication. And I know that's a point that physios do a good job of. So having targeted, physiotherapy. And then the discussion's really healthy within the isometric and the concentric and the eccentric and the progression, and then the plyometrics and this whole art of physiotherapy. I mean, that's what the great physios do, is they assess really carefully. They know the appropriate exercises, which doctors and others don't know, for the different time that the patient is at. And then the skill is in progressing, listening to the patient, judging, testing them and judging them. And that's an amazing skill, which, getting back to the general public, they don't understand the nuance there and how that's a big skill and that you can't get that from anyone else. So physiotherapists are clearly the body specialists in that way. And, that's part of my job, is to be advocating that. And I have been, as you know. So I'm making the point that the change I've seen for tendon management over 30 years, is this greater evidence for exercises and the nuance in the progression of exercises. If we go with Alfredson's heel drop program, Håkan is a friend and a surgeon, and he had a very basic heel drop program with the 180 heel drops, but it wasn't this nuance of adjusting the program according to the patient's needs. And the fact that even that program was effective, it shows you how powerful it was, because it wasn't exercise at its best. And he won't be upset if he hears me say that. And I'll tell him, that I said it was just a basic, here's a surgeon getting you going on some programs. And then you compare that with these world-leading physios in different body parts like Karen Silvernagel, Ann Cools, Jill Cook. They are just finessing the treatment to the patient's needs. And of course, they're going to have better outcomes, and then bringing in other treatments such as orthotics as needed. So all of this, you're hearing me say that I'm not mentioning PRP as a solution, because I'd argue that it's not a solution, but I'll hand back to you first, and then I can expand on that if you want me to. But that's sort of the exercise, my view of what's changed in the exercise space, Mariana.
Yeah, no, I think there is a great progress in all these, the load management and all the treatments that we've been seeing, and like we have these great researchers and great papers being published. So for sure, I agree with that. And I'm curious to ask you about the PRP now, so you can go on.
Yeah, look, I'm in a fortunate position, being an academic, and so able to come across papers like the Robert Jan de Vos he's the Dutch doctor, works with great physios and doctors in Erasmus in Rotterdam. And Hans Toll is just a massive name who's not that well known because he's a humble guy and he publishes amazing papers as a middle author and a last author. And, they did a very nice trial in JAMA, the Journal of the American Medical Association, top journal in the world, of a beautifully randomized controlled trial of the injection of PRP for Achilles tendon patients who'd been well selected and versus placebo injection. And I'm wearing my clinical hat because obviously I was in the clinic and I've seen a lot of patients and I talk to clinicians. What happened in that trial is, the patients, one group of patients did really well. They got better, and they put the data points in their paper. So you actually see the data points of the patients getting better over the 12 weeks and some patients not getting better. But, net, there were patients definitely getting better over the 12 weeks. And it's beautifully shown there in that graph. And that's what clinicians' experience is when they, let's say a doctor's experience, they give a PRP injection and the patient gets better. So as a human being, it's hard not to believe that this is helping, right? The patient's not good. You do an injection, patient gets better. Now, I've deliberately, as I've explained this story, I didn't say it was a PRP injection. I said, one of the groups got better. And that was a placebo group. The placebo group graph, if you look at them, there's a wonderful improvement trend as a group, and some of them spectacular even. But that's the placebo group. And when you look at that graph, and we can put it on our website, that, so I'm going to do this in talks for obvious reasons. But then when you put the PRP group, it's a very similar appearance where there's improvements in some, not improving in others. And the two sets of dots, and I'm doing this signal with my fingers because that's how the dots are lined up. There's no difference between the dots. So you can show, someone this set of dots and this set of dots, and they can't tell you which one's the PRP and which one's the placebo group. So, bottom line is that does PRP injection work in the clinic? Sure, it improves. Some people get better. Should you may as well just save them the many hundreds of dollars or pounds that are being charged for this and say, look, I'll do this for you for free. I'm going to inject some placebo. It's that whole issue about power of placebo, and you've got podcasts on that as well. But I'm just making the point that please, if you're a clinician, don't come to me if I'm a patient and try and tell me that there's some advantage over placebo in PRP because you've seen some patient get better, over PRP. That's, training should stop you from doing that. Like, there's what you see as a human where not better, injection better. It's like, okay, that's a human. But with all our science knowledge, when you have the placebo group, there's no difference. So please don't tell me there's a difference from a placebo group. And then, I'd switch to a different tack. If someone goes, Karim, I don't believe any of that, then I'd say to them, well, what about the biological rationale for PRP? Like, what's the PRP doing? And I'd argue that the people haven't answered this convincingly. And I've been watching this for more than 10 years, because what it says is that there are growth factors. So there's this magic factors, and then these factors make you better. It's like, okay, there are factors. I can run off the alphabet soup as well, IGF-1, all these different proteins that are in the blood and in the body. But that's like saying, you're going to make a pregnancy by having progesterone and estrogen and maybe prolactin and just throw them in some sort of soup. That's not going to get you a baby or a healthy baby, or that's not how biology works. Like, the biology is a complex mix of hormones and proteins and synthesis of material. They can't just be thrown in. Now, with PRP, if you were a patient of mine, Mariana, fortunately for you, you're not. If you choose to come in and get an appointment with me today, the PRP that we spin down today is meant to have the perfect mix of factors for your injury. Let's say I was busy and I saw you in 2 weeks' time. All of a sudden, when we spin down your blood, the 2 weeks' time, the magic factor is in exactly the right proportion to treat your injury on that day. That just doesn't make any sense. Like, it seems so banal when I say it. Somehow the body has got this mix in the blood of the right factors to, magically fix tendons at that day. And I'm sticking with tendons because that's where the very compelling randomized trial evidence is that it doesn't work. So I was comfortable 10 years ago. I said I'd have an open mind, and I've been, I'd say, validated and vindicated that PRP is not helpful compared to placebo and injection, both in the randomized trials. And I'm yet to hear compelling evidence of how the magicians who are putting the PRP in can get those magic growth factors in the right proportion over the right time to make the tendon heal.
Mm-hmm. Well, very, very interesting. I'm curious to see that too. Good point. Yeah. And how about cortisone?
Yeah, good face. Yeah, look, I don't want to labour this because I think, people will get my position. Well, cortisone is actually a tendon poison, interestingly and briefly, and that's been shown by Bill Vincenzino and others over a series of tendons. If we stick with tendons again, the tennis elbow, the elbow tendons, and so that's when they have PRP versus cortisone. The PRP comes out better because the cortisones actually make it worse. And I've made this point in a few conferences where I say, if I didn't really like someone, if I had a patient that I didn't like and they had a tendon problem, I could, and I wouldn't do this medically, but just in the lighthearted way, it's just a thought experiment. I'd encourage to inject them with cortisone because in 1.5 to 2 years, they'll be worse off than they would if I didn't inject them. So, that's the line, is really, if you don't like someone, you want to make them worse than they would be without injecting them cortisone is a good thing. And the data shows that. So go to Bill Vincenzino's papers, go to the systematic reviews and have a look at the randomized trials and the reviews to show that cortisone is a tendon poison. Now, of course, it works well in the short term. And so, just to be evidence-based and clinical and honest, I was part of a team that injected, an elite athlete before a big event, and we don't have to give names because of medical confidentiality. But we discussed in a shared decision-making way, and that athlete had worked with a physio and with me for many years, and they knew that how we felt about cortisone, and patient education. They were well educated, so they knew all that. But because of this big event in 2 weeks, there was a flare-up of their patellar tendinopathy. There was ultrasound, to document it wasn't large tear or anything like that. And so on balance, we discussed it and was like, yeah, I want to take the risk of the cortisone. And obviously I was nervous during the whole tournament, but the player got through the tournament. They had some symptom relief because cortisone gives short-term relief. And so that's a very different setting to, a worker who comes in to a clinic and wants to get long-term cure of a tennis elbow from those trials. So this brings us back, Mariana, to this point that we can, give the literature is so much more powerful than it was, 10 years ago, 20 years ago, 30 years ago. And so I think your profession can just be confident that it's doing the right thing. So when things aren't working out, look back and go, do I need to, is the diagnosis maybe wrong? So let's stick with, the tendon problem where it might be an insertional tendinopathy rather than a mid-portion Achilles tendinopathy. And there might be an inflammatory component. The person might have a spondyloarthropathy, as you know. And so that might be delaying the treatment. So that's a good example of revisiting the diagnosis in the first instance. There can be, in patellar tendinopathy, there can be patellofemoral osteoarthritis and things like that. So, that's a good sort of check. If the diagnosis is right, obviously great physios revisit the exercise program, because it's not just exercise as we talked about. They might tweak the exercises, the range, the dose, the angles, the type of exercise, the recovery periods. So it's this idea of sticking within physio options rather than bailing out and saying this needs an operation, because the evidence isn't there for those things. Consulting other physios, not every physio can be the world expert on every condition. And so this idea of cross-referring, instead of going, I'll refer to a doctor, if you're close enough to live to the physios, live nearby, get the patients close to the physios we've talked about, it's like, look, I can get you to this other physio who is particularly experienced in this condition or your sport, right? And that takes us to the JOSPT podcast where they have Sports Corner. And so I learned a lot on the baseball podcast there by Gareth Bullock, because I hadn't known much about, the throwing issues in baseball. So it's this idea of getting to another physio who might be the body part region, like an elbow physio. And big shout out to Val Jones at the moment, who, has got some health issues. But these, great physios for the region, like an elbow, I'm giving an example, or a tendon, as we've talked about, Karen Silvernagel, or the sport, where there's a physio like Gareth Bullock, who's a professional baseball player and a physio. And we know those examples. Liz Bailey's a good example, as a dancer and been on your podcast. So it's this idea of referring within the physio profession without feeling, I'd much rather be, if I was a patient, I had a foot problem and it wasn't getting better, I'd much rather see Liz Bailey than see a surgeon who doesn't deal in sport but has done a lot of foot operations but doesn't know. So, we were getting there in terms of that was under the sort of management examples, really, and not rushing to these medical solutions, air quotes.
And gratefully today we have these great resources, right? I was just listening to Liz Bailey's podcast on the JOSPT insights that we were mentioning, and it's so rich, so many like good clinical tips and very specific to the foot. I also loved her podcast with me, and as I have with like these, very niche PTs that are so good in their areas, and it's hard. We can't know everything about everything, so it's just like having these great resources that you can go to and listen and try to learn from these people, refer them. I think it's absolutely great too. As we were discussing about the podcast, right? Talking about resources, do you have resources that you recommend? Like you just mentioned, the podcast with Claire, that's really good. Hopefully I'm going to have her soon here on the podcast. We were talking.
Great. Yeah, no, look, congratulations to you, Mariana, on your podcast series, because, as a, outsider, not one of your social network of friends, this is the first time we've talked this long, apart from planning, the podcast. You've done a great job with your series, and it takes a lot of work, let's be honest, because we know that, there's an expression in Australia, every man and his dog. It's a bit sexist, I guess, every person and their dog. But, there's a lot of podcasts out there, and let's be honest, I can be honest, a lot of them aren't very good. So, they're just sort of wasting the listeners' time because the folks aren't doing the homework that you're doing and preparing and doing the quality podcasts, and people know that. So the challenge for the listener, someone like me, is I've got time to listen to some podcasts when I'm walking the dog, sticking with the dog theme, but I don't want to have my time wasted by a couple of bros sort of chatting about the weekend when that's not what the podcast is meant to be about. And so congratulations to you and, the people who are doing a great job. And I enjoyed the Ebony Rio podcast on yours, because you've got the long form. I think different podcasts can do different things. So we've had a chance to have a much longer chat here than we would on some podcasts. And you give as you say, the expert like Liz and Ebony and others a chance to go into depth. And hopefully there's some value here for people who have got the longer period of time. Claire in the JSPT Insights is pretty focused on the 20-ish minutes to go. This is like that podcast. And I think she's got, and I want to shout out to Chelsea and Dan, who lead the sports. The sports corner that I just referred to before. So nice variation between the interviews that Claire does and then the sports focused ones, as you mentioned. And then, I was fortunate to be in the podcast space myself. And from 2010, I'd say as a pioneer in the space, I was lucky because there wasn't any competition there. And we got lots of feedback from people that they loved the BJSM podcasts that we launched, and we had the app, and people would come up at conference going, I love the BJSM podcast and I love the app. And of course, a big shout out to the current editor team led by John Dresner, and they've been in that role for more than 5 years now. And most people have forgotten that I was involved in BJSM, which is healthy. But there's great quality podcasts there, and people like Brooke Patterson does interviews, Aaron Macri. So they've got many physios who are doing podcasts in that channel of the 25, 30 minutes, which, is more medical compared to some of the podcasts and physio, and obviously is good quality there. So I see them as a couple of the things to remind people when they're looking frustrated that they're on a bad podcast. Think of yours and Claire's and the BJSM. And then at the Clinical Sports Medicine homepage, the plan is to have value on a 3-part homepage. But, if folks can forgive us at the moment because we've been busy getting the book out. But there's stuff about the book as a one panel, there's courses in the middle panel, and the third panel is called the Hub, and that's meant to add value if people are saying, look, what's a trusted resource? But I don't want to labour that here now, but hopefully people will enjoy that site and we'll point to your podcasts and other things. So our job, I'm not getting back into the podcast business, which listeners will be pleased to know about. But we'll be pointing to the podcast, maybe making a comment, right? Saying, look, here's 5 minutes from maybe me and another guest on why Mariana's podcast with Liz Bailey was great. So this idea of just trying to be a guide and help people find the good things is what our role is on the Clinical Sports Medicine website once we have time to get it up to date.
Yes. So you were a pioneer on the podcast industry before it was even a thing, right? That's great.
Yeah, credit there. I mean, we always, the great people, they know who gave them ideas, and they know it's a team effort, and they don't come up with ideas themselves. I didn't come up with the idea of podcasts, obviously, but being in the British Medical Journal group, which was a great privilege, we had a new graduate from communications called Claire Bauer. And the BMJ was smart enough to, very visionary to hire her in 2008 when, American Journal of Sports Medicine and these other journals weren't thinking about this stuff at all. And then and because of the beauty of the BMJ group is there's 70 journals now, 20 then, but they were covering a lot of journals. And so the, journal, just a small journal like Sports Medicine, we got the benefit of this powerful BMJ group. And then she said, look, here's this thing that's happening, Twitter, here's this thing that's happening, blog, here's this thing that's happening, podcast. And so obviously I was just open, and with Jill Cook and Kate Crosley and others, we were open to the idea. And so we just got mentored, and we just, we actually sent a headset to our first guest in the mail so they could get some sound quality. And then the technology, obviously apps came in so you could make it smoother, and the editing software came in. And so the field has moved dramatically forward, as people know. But just a little historical note that, there were visionary people. And then, I think it's reasonable to say we were social media pioneers in that space because there was no one else in it. And Claire Bauer deserves the credit because she pointed that out to us. And we were realizing that, that is important. That's a critical channel. Thanks for giving a chance to flag that. But the current people are doing way better, of course. And when I listen to those old podcasts, I'm a bit embarrassed about my side of the microphone. But the guests are awesome, and that's what you're saying. You have got fantastic guests, and then you add value yourself, and so now it's a much better product. And so well done to you, Mariana.
Thank you. I'm glad to hear that. And also the technology advanced a lot since you started, right? So you have
Absolutely.
so many new things, and social media and YouTube now just growing so much. But you help to grow their, social media outreach and podcast. That's awesome. So
yeah, we're happy to experiment, right? We're in a lucky position. The BMJ group let us experiment. So Babette Plom, another editor, she was out with a handheld H2 microphone recording at conferences, and they were very supportive. And it speaks to LinkedIn, of course. If we talk about the current options, YouTube obviously is massive now. LinkedIn is very valuable. People find that valuable. Instagram. I'm not the TikTok generation, but of course, there's lots of messages going there. You can tell me more. I'll ask that as a question. What do you think about TikTok at the moment?
I am not on TikTok. Everybody's saying that you have to go to TikTok, and I haven't had the courage to start on TikTok yet. But
Well, it's hard, right? You can't be on every platform. That's the challenge, and the platform values change. So I wish you luck, and that's where you're doing a great job. Claire's doing a good job. BJSM has a range of platforms. So I think one of the keys, if I may, is just to say that you bring different people onto different platforms. And so when we were in the BJSM, the Facebook was led by Stefan. I just didn't mean to say the Facebook in the boring, it's almost a joke, the Facebook, but Stephen Griffin was doing Facebook, and different people were doing different platforms. So one person had their favorite platform, and then they could have fun on that platform. And, Claire's got different folks on Instagram and LinkedIn and things like that. So I think that can be one approach, is to use, because you're speaking to different audiences on the different platforms, obviously. And so you want the person who's running the platform to be of that audience and to
yes,
get a
and you
feel
have
for
to
it.
produce different content. So then it's a lot of work. You have to have a team that produce different content to different platforms. It's a lot. So
Yeah, but congratulations. I think having a great product and working on it makes a lot of sense. So thanks for everyone for getting your platform out and having this reach that you have. Well done.
thank you. I'm appreciated. And then Karim, do you have any advice to clinicians that are starting their careers?
Yeah, and I know we're coming to a close here, and I appreciate the opportunity. I think I just feel mixed about advice, because it sounds like you think you know everything, which isn't my style, as you know, and I know you weren't coming across in that way. I guess what I've observed and learned, you get a chance to observe, right, if you're old, and see. And I've been fortunate to be in different settings, so I've had some great opportunities in, the Middle East, in Aspetar, in Canada, in Australia, conferences. I think the young clinicians who do well, and I know you have an audience of a lot of younger clinicians and early career folks. Um, working hard goes without saying. So you can't sort of spend a few hours, the 5-hour work week. I haven't bought that book, and I'm sure it's great, but it's sort of hard to believe that the solution is with a short period of time. But I think you can also work hard, not efficiently. So I think, and I argue I haven't been that efficient necessarily. My colleagues will know with my failed deadlines, and when we had to delay a podcast attempt. Sorry about that. So I'd say try to find. If you can find what you're passionate about, either a sport or a body part or biomechanics, so that this thing that drags you there anyway, obviously that makes it a lot easier. So, when I do work, on book editing, it's like, look, this is an important product. I feel good about it. It's not like, I wish I wasn't doing this. Okay. So find the thing that you like to do, and then put the time in that area. It's easy to say. And I think the challenge is to try to find someone who will mentor you and support you and help you grow in that area, because everyone's busy. So let's say I have a new life and I want to become, a much better foot, physio. So this whole new life, right? But what would I do to just try to make it concrete without the privilege that I have? Then how could I get Sue Mays from the Australian Ballet or Liz Bailey or someone like that to give me time? If I email them and go, look, can we have a weekly conversation where you mentor me? It's just not on. And that's the barrier I think people who aren't in these privileged connected positions find. And I think what I'd suggest is to try to see how they can add value in return when they're approaching. So, maybe write to Liz Bailey, and she may not be grateful for this. Say, look, is there something I can do to help? Like, are there, papers that, you don't have time to read, but you want me to read and, summarize? I mean, I'm just being a bit academic in this context, but in the physical space, Paul Blasey, who was a junior junior physio when he met, was kind of looking for mentorship in a way, but instead of saying, look, can you mentor me and put me, into a PhD program, it was like, how can I help you, Karim, right now? And so there were things that he could help with in sports. He's a sports physio, and so he helped work on the 5th edition medical book, for example. And obviously we paid him, so not taking advantage of him, just to be clear. But, he just did a superb job on that opportunity where he was being paid not at a super top level, it was like semi-volunteer. So the word I often use is strategic volunteering, where you don't often do photocopying for someone famous as if that's going to help, but you try to get into their orbit, but you've got to try and do something for them so that because they're giving up time to mentor you. And so if you can free up some of their time with what you do, then it makes it worthwhile. And I think, I've been fortunate to be in a mentoring situation, and the folks and so I guess these junior doctors who did the social media for BJSM, of course, I'm going to spend time with them, with their career development, unrelated to the social media they were doing for us. So, and that could be in the JSPT space, it could be in your national organisation space. And Emma Stokes, the former president of World Physio and very well known in the physio world, she made the point of volunteering in the World Physio, as it is called now, when she was junior and a young physio. So you could probably do a better job of summarising that more articulately and more briefly, Mariana. But how does that sound?
No, I think that's a good strategy. So you're bringing some value to them, right? So you're not just asking for their time, you're potentially giving back some time to them as well by doing something. And younger people, they know more about social media, maybe it's easier for them. They grow up with that. So even offer to manage social media. I don't know, something that would be valuable. So I think that's a good tip, good approach.
And the challenge, is getting paid right, not to being taken advantage of. And sadly, there are people who will take advantage of you. So I guess another, observation, and I can say this to be honest, there are dysfunctional people, and not everyone's great, and not everyone, and even famous people aren't always great and functional. So I think, just to get the elephant out of the room, it should be an obvious statement. But some people have been in sheltered lives where they've been well cared for, and they just assume that if someone, who's got some degree after their name and some publication or something, they're a good person. But, in our very field, in sports medicine, in sports physio, I can name very dysfunctional people, and they've been on charges and they've been kicked out of universities. But because of non-disclosure agreements, it's tricky for that to be public, So, and then it's important for people informally to spread that word, to say, this person is dysfunctional. It's not safe to be around that person. But the problem with the lawyers is that you can be sued for saying that, even you being true. So I guess, that's an important point to realize not everyone is ideal. And so then to trust your instinct, and if you're getting a feeling that this person isn't safe, either in any physical way or just in taking advantage of you, then don't go, but they have all these degrees and these publications, so therefore I'm wrong. Look, trust your instinct is my message. And that could be the most important message that I'm giving on this podcast for folks just generally, because I'm in a position to be able to say that. But then, finding those good people, then you can add value and think of I think that's the intimidating bit for folks, where they go, well, I'm just a junior person. How can I add value for Mariana or for Claire or for John Dresner, or Joe Kemp, and it's like, well, just think and try. And it doesn't have to be the world number one person straight away. Like if, it's like someone in your area who can mentor you stepwise is the point, you made. But it's this strategic volunteering, but trying to think how you can add value and ask. And you made the point about, young people have time. You've got to find the time. What's your asset, right? You don't have experience or necessarily knowledge, but if you come from a sport, that's a massive advantage. So if you're a former ballet dancer, you could, or current ballet dancer, you could be in the clinic and watching, but saying, look, I can help educate the other physios about ballet technical aspects, for example. So you sort of don't give up on that you don't have anything to add. Think what from your life, do you have already, or can you read up on, coding and AI and, these sort of things. So you have to be proactive. But that's and observations I have, Mariana. I hope some of that's helpful.
No, very good, very helpful. And before we wrap up, Karim, anything else that you want to add about everything we just mentioned? Anything that we forgot to say, or any final thoughts?
Yeah, no, I think I'm grateful. I'm grateful. I think we've covered a ton of territory, and I really appreciate this opportunity, as you know, and it's been really fun to be chatting with you. I look forward to letting people know about it when it's out. No, I think I'll finish by just being authentic about what a fan I am of physiotherapy, the profession, for its effectiveness in sport. I think it's really, really powerful. the most powerful single profession in some ways. I mean, you could always debate how you set those things up. Obviously, if you've got a femoral stress fracture that's turned into a full fracture, you want a surgeon in that situation. But obviously, I think the profession, I think of people like Gwen Jull comes to mind. There's someone who's just great, and just there's so many role models that physios can be proud of who are doing superb work. Par excellence. That just unarguably. So just go that as a physio, you can be very proud of the profession you're in. And then obviously the people, that's the professional angle. The people I've been fortunate enough to work with have been amazing, just a gift to my life, and they know who they are. And so it's a gratitude from me to say I feel fortunate broadly and specifically, and I hope that I can keep adding value so that ultimately the athletes, getting back to those patients in Chapter 1 in Foundations of Clinical Practice, are taken care of, which is so motivating for all of us.
Yes, no, that's great. And if people want to learn more about you or find you, you have the website that has a lot of good information, right? What is the website?
Yeah, I think if you be patient with clinicalsportsmedicine.com, and the contact there works. So it comes to me actually, so yeah, and I've got an email address. My professional email address is easy to find. And if I seem to ignore you, it just means that I'm not perfect at email. It just means that I've messed up. So feel free to try again, on that way, or LinkedIn. I'm working on LinkedIn. So it's pretty easy to find, I think, really through those channels, Mariana.
Okay, great. The website and the LinkedIn. The website also has a lot of information about the books, their contents. If you're curious to read, you can go there and find more information. I was just browsing through, and a lot of good things there.
Thank you. Yeah, our website managers are great, White Leaf. They do a great job. But I've just been, you can imagine it. I just want people to be forgiving. I'd respectfully ask if people didn't mind being forgiving with, juggling. So the website's not perfect at the moment, but once these books are out of the way, the second books into publishers and things, we can give more attention to getting that more useful.
Yes, you've been busy with the book, so I'm glad that it's almost done, right? So
Thank you very much.
second one almost out. So yeah, and then come back to tell us about the second book.
I'd love to chat about clinical tips and hopefully some of this is interesting and people can suggest what they liked and what they didn't like, and always happy to try to be helpful, Mariana.
Very good. Thank you so much, Karim. Thanks so much for your time. Appreciate it. And have a great rest of your day.
Thank you. Bye-bye.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.